Hello everybody, my name is Laszlo Parkanyi. I'm from Szeged, Hungary, and I'm really excited to have this webinar with Botis today. And I come from Szeged, a little city in Hungary. I teach at a university here. I also run a private practice here in Szeged and another one in Budapest. So I love living, teaching, and working here. And today we are going to talk about bone grafting in present days. And why is that the title of my lecture today? I believe that bone grafting in regenerative surgery and implant surgery is one of the most important topics. And I believe that also in this topic, in this subject, there is always a past, a present, and a future. And it's not static, it's not the same. So we are doing bone grafting for decades now, but as we all know, also the techniques as the materials are changing, they're developing, they're evolving, and we must not stick in the past. So we must know what techniques, what graft materials we were using in the past. Sometimes we have to look back and use materials from the past, and we have to evolve with the new materials and place it in our daily clinical practice. And there is a chance that the techniques and materials we are using today, in 10 years, we will say that it's not the high end, it's not the state of the art, because we are evolving and changing. And as dentists and scientists, we have to be prepared for that. We need to change as technology and the science evolves. So that's why we're talking about bone grafting in present day. So what's the evolution of bone grafting today? Where are we now? And we will see where we'll be at the future. Okay, so let's just quickly see what our aim is today when we are doing any type of bone grafting. So in every case, we either want to prevent or reduce bone resorption, which is basically remodelation in the alveolar process, or rebuild horizontal and or vertical loss of the alveolar bone that already occurred. So we either want to rebuild the bone which is lost when we meet that clinical case, or especially today when we are doing more and more immediate cases, we might just want to reduce the remodelation, the resorption of the bone, or if we're thinking about state-of-the-art techniques, we might even want to completely prevent that if we're thinking immediate. So let's step one step forward and see what indications do we face day by day in our clinic when we are challenging bone augmentation. And let's go from up to bottom as difficulty increases, I think. So although immediate implant placement is far not the easiest regarding implant placement, but regarding bone augmentation, when we do immediate implant placements, the bone grafting part of it is usually just the grafting of the buccal gap between the implant and the buccal bone. So bone grafting wise, it's sort of the easiest case most of the time. Then comes the vertical augmentation in the lateral maxilla. We all know which technique that is. And it's still a contained defect. As the alveolar socket, the sinus is also a completely contained bony area. So still the easiest parts regarding bone augmentation is when we have a surrounded, bone-wise surrounded contained area. Then comes the non-contained area, which is a horizontal augmentation of the ridge, already resorbed ridge. But when it's minor, when you have a single tooth gap, it's always easier, and it gets more difficult when you have a major resorption of the jaw bones horizontally And generally, it's a multiple teeth area. It gets more and more difficult, less and less contained defect. The bony walls, the stability of the surrounding bone is less and less. And the most difficult case, I think, in my opinion, is when we have also vertical component, when we have vertical bone loss in either of the jaw bones. And when we have vertical, I believe we must say it's a horizontal and vertical augmentation, because when we have a vertical loss and we want to build vertically, of course we also want to build horizontally, because we need 3 dimension for our implants. So it's always a combined horizontal and vertical defect. So let's see, as name of techniques, the most general, most commonly known and used and evidence-based techniques which we use for these situations. So when we're thinking immediate placement, we can use the classic dual zone technique prescribed by the starter professor, or the much newer socket shield technique described by Professor Hertzler. Then we go over to the sinus lift, of course, which is the vertical augmentation of the lateral maxilla, which can be an open, it's a minor sinus lift, a closed sinus lift, which is a minor one, or an open, which is a major, larger sinus lift. Depends on the excess of the sinus lift, not only the area or the volume grafted, but also the excess if it's open or closed. Still contain defect. Then comes the minor horizontal augmentation, which is classically called the contour augmentation after Professor Boozer. We all know this technique, how we can graft the buccal missing bony volume one stage with implant placement. This is the classically prescribed technique for like 30 years. Then if we have even more severe resorption of the ridge horizontally, and generally it's a wider tooth span, so it's not a single, usually a multiple tooth span horizontal defect. We can either do the ridge split, which can be a one-stage ridge split with the implant placement, or a two-stage GBR, which is classically after Professor István Orbán called the sausage technique. We also all know that. And when we have the vertical defect, vertical and horizontal defect, which is the most challenging, I believe, then we still have some techniques which we can use. And we all know that vertical GBR with titanium mesh or titanium reinforced Teflon membranes exist. It's possible to be successful with that. But I believe it's the predictability and the reproducibility regarding major vertical and horizontal defect. It's the most challenging, and I believe, in my humble opinion, is maybe the least predictable. So when we go the most major defects, horizontal and vertical, my choice would be the Cori block. So let's see the materials used in either of these situations in these cases. Today, I think we know, and the literature supports that if we do immediate placement and only want to graft part of the socket within the treatment of the implant placement in one session, we can use only bone substitutes. We definitely do not need any autogenous bone. If we do sinus lift, regardless if it's an open or a closed sinus lift, we always can use bone substitute alone without any autogenous bone. It's well supported by the literature. There is evidence behind it, tons of. When we do a ridge split, of course, we already have some autogenous bone because of splitting the ridge. So there we do have autogenous bone. And if you think about the sausage technique prescribed by Dr. Orbán, we all know that it needs, beside a xenograft, beside the bone replacement material, it needs a great portion of autogenous bone as well. Without it, it will not work in these major horizontal defect cases. And if you think the Cori block technique or modifications of Cori block techniques, we know that the purpose of this technique is to only solely use autogenous bone. So I believe, as you can see, that regarding materials, most of the cases you can use either only bone substitutes or a mixture of bone substitute and some scraped bone. But in the most demanding cases, it's maybe the most predictable or the safest to still go with the full autogenous. So let's see the grafting materials which we have today, the most common grafting materials. First, we have the autograft, the patient's own vital bone, scraped or blocked, whatever form we take it in, but that's the gold standard still. We use it for decades. It worked 20, 30, 40 years ago. It works today. But of course, we know it's the most invasive with all its advantages. That's a major disadvantage. So the xenograft, that's, I believe we can say, the gold standard in bone substitutes. Why do I dare say that? Because for the longest time, we have the most literature, the most evidence, and the most clinical experience combining all of bone replacement materials. The xenograft in bone replacement today is, as gold standard, is the xenograft. We have tons of evidence for that. Allograft, we know it works, several materials for that, but the volume stability is not as high as the xenograft. That is a fact. Also, while it might have some osteoinductive potential, the osteoinductive potential, of course, it is not nearly as inductive as the patient's own bone. So something in between, let's say the xenograft and autograft. And the synthetic bone filler materials have at this time the least literature and least experience compared to xenografts. At least there are lots of materials on the market completely synthetic, but some of them are known not to work as well. Some of them work better, but they're changing. There are many of them, and there is no one material which is proven to work in major defects using just synthetic bone minerals. No specific techniques yet widely spread in the literature using just synthetic or mainly synthetic materials. So at this time, at the present, I would say it's the least predictable bone replacement material. So why do I go for xenograft if I want to build a bone, if I want to replace at least partially or entirely the autograft, the patient's bone? So it has definitely the most extensive evidence in the literature of all bone substitutes. We have it for decades now, the xenograft, not only the autograft, even the xenografts, we have decades of evidence behind that. It also has the most volume stability of all grafts, and here including autografts. Of course, autografts, the patient's bone has much more vitality and living cells, but it has a much greater shrinkage, which is a disadvantage for the autograft and advantage for the xenograft. And like, of course, every bone replacement material, it has no morbidity of any kind because it's out of the box or bottle, we know that. And it is suitable in most bone augmentation situations alone or in combination with scraped autograft. So only the most demanding cases, I believe, are the ones where it's not safe to use it alone or in combination in something which is mostly the vertical defect. So let's see, that was enough of the talking, so to say, so the text. So let's go now for some images and let's see some cases for every clinical indication which I mentioned previously, and let's go down on the difficulty from top to bottom. So let's start with immediate implant placement. First case here is the immediate placement dual zone technique according to Dennis Tarnow. So it's sort of a classic immediate placement case. You can see on the x-ray vertical fracture of the tooth, which is an endodontically treated tooth. We had to remove the crown and the root, obviously, of course. You can see here from the incisal, we have a huge prominence of the root of the premaxilla here. And when we remove the root, unfortunately, we can experience that there is no buccal wall at all. So this is quite a difficult case for immediate placement. However, if we have quite a volume stable, stiff collagen membrane, that like the cold protect membrane, we can do the so-called ice cream cone technique. Similar to that, we place it to replace the buccal wall, place the implant according to a surgical stand. You can see the collagen membrane on the buccal, and regular cerabone at this time, we didn't have cerabone plus at that time, put into the buccal gap. We fill it up. You can see that the particles are somewhat here and there. It's not really in one piece, but this is just regular cerabone. We know it works very well from the literature. It's filled up. We do not have a major stability here, so there was just a provisional Maryland bridge for the healing. But after the healing, after the fabrication of the provisional crown, we can see that we achieved quite a nice shape of the soft tissue, quite a nice architecture of hardened soft tissues as symmetric to the contralateral central incisor. We can see that we regained the prominence of the previously lost hard and soft tissues. Even some particle, cerabone bone particle incorporated in the soft tissue, but obviously no inflammation of any kind. That is actually the point of dual zone technique. So in the bone level, we have the bone particles incorporated into bone and have new vital bone. And above that, in the soft tissue level, we also have bone replacement particles incorporated in the soft tissue, which keeps it thick, keeps it stable, volume stable for a long time, and that's the purpose of it. It's no problem, we have it incorporated, and as you can see, the crown here, our aesthetic result and biologic result is quite pleasant for the patient. Let's see another case. Here is endodontically treated, fractured, failed tooth. It's first bicuspid, also a fistula we can see there, but it's not active. So we extract the tooth, clean out the alveolar socket really thoroughly, place the implant in the perfect prosthetic position. And in this case, we already had the cerabone plus, so we fill the buccal gap with the cerabone plus. You can see it's much more nicely contained within the gap. It keeps itself together, sort of. We just provisionally put that healing screw in there, and in this case we do immediate loading, which we can do with today's high primer stability implants. So this provisional crown is delivered a couple of hours after we extracted the tooth, as soon as we get it from the technician. And as you can see, there's a little particle or two in the soft tissue. It's just right after delivery, but it perfectly keeps our contour, and we will have perfect tissues on the long term around this implant. So these dual zone implant techniques I just showed are to reduce the remodelation and the buccal tissue change, the hard and soft tissue change in the buccal. It reduces it. By reducing it, I mean it doesn't stop, it doesn't prevent it. But today we know that we can completely prevent the change, the resorption, remodelation of the buccal tissue. This is called the socket shield technique. Here, if you look at this lateral incisor from the buccal, you would see, of course, it's endodontically treated, discolored, but why do we extract this? On the right, you can see that about 90% of this tooth is composite, so we basically have no ferrule, no tooth structure, just on the apical a millimeter or two. And if I put here the CT scan, we can see that although we don't have any crown structure, they're just composite, it also has a sort of internal, external, or both resorption of the root, as you can see at the cervical area. So definitely this tooth, this root is not salvageable, so we need to extract it. However, the buccal root part seems to be, as you can see on the CT, completely healthy. There's no damage there. So here we do the socket shield technique, dissect the root, remove the palatal part, create the shield. I use Professor Howie Gluckman's PET kit, which is really an amazing tool to create the perfect shield for the implant on the palatal with sufficient primary stability. We place an anti-ridge implant in this case, and around the implant at the buccal area, we fill it out with cerabone plus. If we look at the literature behind socket shield, most of our articles, most of our literature say that still it's advantageous to fill the gap with bovine bone mineral to have perfect tissues for the long term around that implant. And we can see the immediately chairside fabricated composite crown, which I did right immediately after placement of the implant and those bone particles. You can see here already that the bone, the cerabone plus keeps itself so nicely in place when you learn to use it. It's about, I don't know, the second or third time I've used it. And when I put in the crown, there's not even a particle or two at the soft tissue level. So it completely, perfectly keeps itself in place, in its volume, in its place where I placed it. And about a week or so after, you can see it's so beautifully incorporated. Look how the tissue is attaching to the cervical area of that composite, not even too smooth crown. I mean, as smooth as it gets with a provisional, but you can see it's beautifully attached like if it was a real tooth. Just a couple of days after delivery of this provisional crown. And because what the patient wanted to see, sort of was concerned about this technique, the socket shield, what happened here, wanted a CT by herself. So I said, okay, let's do it. I wouldn't do it like regularly, a CT scan after a socket shield, but let's see what we have here. It was about a month or 2 or 3 months after the intervention, the surgery, and you can see, you can appreciate the shield buckle to the implant, and also that the consistency, the radiopacity of the natural buccal bone of the patient and the bovine bone mineral, the cerabone plus placed into the gap, basically doesn't differ. So you need the shield to differentiate the patient's own bone from the cerabone plus particles, because it's incorporated so quickly, so beautifully, just about 2 months after surgery, that you cannot distinct the two areas, the two materials from each other. So it looks exactly like the patient's own bone. So it's amazing to see so early, and even the soft tissue reaction, amazing after a couple of days. Let's see another case, typical case when we do immediate full arch, like an Olm 4, Olm 5, Olm 6. Everyone does these kind of cases. So here we had to extract a lot of roots, basically not even teeth anymore, just roots. The bridge came off with the crowns itself, and you can see full of caries, so nothing salvageable in this mouth. Unfortunately, we need to extract all roots. Place the implants immediately. It was an Olm 5, Olm 6 case, I believe. And you can see there's a buccal gap typical in the anterior area from the implant to the buccal wall, even a little missing of the buccal wall. You can see at that implant that we have a not complete buccal wall there and really thin. So we really want to augment it to have a nice convexity, especially in the interior area, to have nice cleansability, nice aesthetic, of course, and especially nice lip support for our fixed partial screw retained denture, which we will deliver to the patient. This is not cerabone plus, this is regular cerabone at this stage. We fill up these gaps, and as you can see, the final multi-units placed after healing, we have a really nice convex rounded shape of the alveolar ridge, no concavities where we place those implants, where we had those thin, not even completely intact bony walls, which will help a lot for the patient's cleaning and lip support. Here we see the try-in of the prosthetic, and here with the consent of the patient, of course. Here is our really happy patient where it's difficult, I think, to spot out that he has a complete denture and not his own teeth. He's really happy with it, and I think we have a really natural look, lip support, and prosthetic result here. So let's go one step forward in difficulty, vertical augmentation in the lateral maxilla. Let's say by name the sinus lift. So first, let's go with the small one, the closed sinus lift. From the closed sinus lift, it's not too much you can see from the clinical pictures, right? So you do it within the osteotomy. So here we have the osteotomy. We place the cerabone plus here. You can see that it's like a big chunk of bone, so it keeps itself in one piece. When I hold it on the spatula, it doesn't fall off for a while, so it's really amazing how you can handle this material. I just tuck it in a couple of small pieces into the osteotomy. Here is the other side of the same patient, just a single implant, do the osteotomy. Here I also have, look at how the hyaluronic acid is sort of keeping it in one chunk, which is also really advantageous when we push it through to the sinus. It will not go to little pieces, all the particles, but it will keep itself in one piece, in one chunk, in one sort of bulb at the apex of the implant to really hold up the membrane, keep it elevated where it's needed. So I'm just pushing here the material through the osteotomy. Here it's already in. Some particles, of course, through this really small osteotomy are kept outside, but most of the material goes in. I place the implant. So let's see the control X-ray. It's a couple of months after, before we start to do the prosthetics, which is now done. Even on the right of the single implant, you can see the texture of the bone on the apical of the implant, and you can still appreciate the initial outline of the sinus, which is more coronal to that, but we have nice bone on the apex, and you can especially see that on the right side of the image, right side of the patient, where we have the two implants next to each other, and at the distal implant you can still appreciate the cortical of the previous sinus outline, but you can see a hard cortical sort of horizontal line which is above the apex of the implant. You can see a clearly visible hard cortical line which formed a completely new natural bone above the apex of our implant. So it's amazing to see. It's just, I think, 3 to 4 months after surgery. So we have a new cortical outline which is completely in another vertical dimension as we had the sinus floor. So we can see it really nicely works. Okay, let's go over to the open sinus lift. Here I have a couple of interesting cases. So the most interesting is, I believe, when we have either different techniques or different materials in the same mouth, okay, and same jawbone. Here we do same technique but different materials, a little bit different materials, and we will see some differences which I think is very interesting. So this is a bilateral open sinus lift. On one side we use cerabone only, on the other side we use bio-os, because I still had some in the cupboard from long days ago. I don't use it anymore. I always turn to cerabone and cerabone plus in my augmentation cases. So we do the, with piezo device, I do always the sinus window, elevate the membrane, and because we needed a large amount for this sinus lift, and I just had this small particle cerabone plus at that time, so I mixed it with large particle regular cerabone, so I have more volume, but most of it, as you can see, is cerabone plus, but it's mixed together with regular cerabone, but both cerabone with the hyaluronic acid. All right, so we fill in the defect with this cerabone plus till the top, place back the sinus window, close up. Other side of the same patient, same day, same jawbone. Also, the bony window is done on the sinus, membrane elevated. And here you can see a little bit of the cerabone plus is still remained from the other side. So of course I will use that, not to throw it out. But on this side, you can really I think, easily distincted from each other. This really whitish, of course, also bigger particle size bio-os, which looks really, really different from the cerabone, I believe. So, of course, this little cerabone I mixed into this 80% of bio-os. So, basically, most of this area, almost the entire sinus is filled with bio-os. And the bony window put back, I use it always instead of the collagen membrane because it's a natural collagen membrane. It's like a puzzle with living cells, so it will not move with this thin cut of the window. It precisely fits back, sticks there, and I will have a reosseointegration and no particles sticking out. Here I have a side-by-side comparison of the two materials. Two sinuses, same time, and you can see the color differences also in the two bio-os and the cerabone parts. I think you can also appreciate that the cerabone plus has this hyaluronic acid in between it, and look at the blood surrounding difference between the two sides. We have some blood infusion on the right side, of course, with the bio-os as well, but look how much more blood we have just a couple of seconds after insertion of the cerabone plus, but we'll see this much better in later cases. But two materials even look really different, I believe, in a clinical picture. Let's see the x-ray. That's right after the surgery, okay? So patient's left side is the bio-os, our right side, and the patient's right side, our left side, is the cerabone plus. So what you can appreciate already here, I think, this is not histology. No one should think that. But if we just look the radiopacity of the two materials, you can see that the bio-os is really, really radiopaque. So it's almost like a white white area, like a white little ball or something in the sinus, which in color, in texture, radiopacity and texture also really different from the patient's own bone, the autologous bone. If you look at the patient's bone, the autologous bone, and you look at the bio-os graft, you can sort of outline the area where we have graft material. It's so different in texture, in radiopacity. If you look at the other side where we have cerabone plus, you can see the structure and radiopacity of the material and the patient's own bone is so similar. You can hardly make the difference where the graft starts and where you have the patient's natural bone, right? So it's so similar. This is not histology, but still, if you look at a radiograph, I think it's nicer to see something which on a radiograph looks exactly like the patient's own bone, unlike the other side. But here's another interesting thing. This is 6-month healing, implants placed, and look at the two sides now. More than 6 months has passed. It's a foreigner patient. I didn't see how much movement, jumping, or workout he has done after the surgery. Of course, I forbid all that to him, but I don't know how he behaved. But still, let's say he did a couple of push-ups or jumping jacks or something. On the right side where we had the cerabone, you can still see a perfect, nice, rounded outline of the sinus graft. Exactly how we placed it more than half a year ago, right? Even after placing the implants, nothing has changed. We have a beautiful 100% outline as initially on the graft. And on the other side, where we also had a nice big outline of the bio-os sinus graft, you can see that especially on the mesial part, it's sort of, I'm not saying it resorbed because we know xenografts cannot resorb that easily, but maybe the particles shift and moved just because of the patient's natural movement. So on the right side where we had cerabone plus hyaluronic acid keeping the graft in one piece, keeping the graft mutually together in one chunk, it stayed in one piece, and we can predict our outline, our volume of the sinus graft. But on the other side, we have probably some shift of the graft particles not kept in place, And on that middle area between the two implants, it's sort of, we do not have that much volume, right? So it moved the graft a little bit. So that's interesting. Let's see another case, other bilateral, same time open sinus lift. So here we have cerabone both sides, but one side is regular cerabone, the other side is cerabone plus. Same material, but not exactly the same, right? So one is a little bit different from the other. Let's see what the difference is. So here we place regular cerabone on the right side. Of course, we know it will beautifully integrate, but right after placing the graft particles, we can see that it's sort of dry. Of course, there's some little blood on the edges, but it didn't get infused with blood in the first couple of seconds, right? We can see that it's sort of dry, but of course, with time, it will incorporate, no problem for sure. Just place back. I even shifted a little bit this sinus window so we can still see it's not full of blood. Still, when we place back the window, we suture it up. Let's see the other side. Same patient, same day, same jawbone, other side. We create the sinus window. Actually, these rectangular ones with the thin piezo, I prefer more because it will get a more stable place and area for the sinus window, bony window, when we place it back like a puzzle, okay? So elevate the membrane, we place in the sinus graft. Here you can see, which is one advantage of the cerabone plus, that the bone around it is completely clean. We don't have to be afraid of the particles, moving all over, incorporating in the soft tissue, causing aesthetic and maybe even inconvenience problems, maybe even minor pain for the patient when the xenograft particles are in the soft tissue. Some of you might have experienced that. I have certainly experienced that previously, but with this material, you do not have that. You take a couple of chunks of this cerabone plus, you just place it in 2 or 3 big parts, and it's full. It's quick and it's clean and easy. You can see the hyaluronic acid in between the particles, and these two images, which you can see, it's about 3 to 5 seconds difference between the two. It's like tuck. You do two pictures, maybe 2 seconds, all right? And on the left side is immediately when I put in the last part and I took my camera. The other one is a couple of seconds later. And look at the difference in blood, in bleeding immediately. So it's the same patient. The other side didn't bleed at all in the first couple of seconds. On the left image, you can see a little bleeding on the right, but on the right one, I can see on the right, on the middle, and in the left. Right? So just instantly when you place the graft, after a couple of seconds, you will have blood infusion, perfusion between the particles. And supposedly, I believe that will give maybe more extensive and maybe quicker vascularization, as you can see in these images. So, bony wall back, we close up the area. So let's see side by side the difference. Same patient, same jawbone, same day, almost same material, okay? So on the left side, we see cerabone. It's kind of dry, no blood immediately after inserting the material. And some particles you see on the bone around it, sort of little bit goes around the bony window. On the right side, we have completely clean area, no particles next to our window, and already blood-infused particles after a couple of seconds. Looks already more vital, right? So that is the difference which you can instantly see with the new cerabone plus. Here we can appreciate the two areas on the control panoramic x-ray, texture and radiopacity, really similar to the patient's own bone. Let's see another, but the last open sinus lift, not to get bored with this. Here I did it to a colleague, and here I already had the large particles, cerabone plus. You can see it infused in the hyaluronic acid, sort of gel-like a little bit, And this is one chunk I held up. It was like one chunk, maybe 2 or 3, and in 1 second, not 1 second, in 10 seconds about 1, 2, and 3 parts, you can fill up the sinus. So it also really goes quickly, but that's not the most important part by far. But it's clean, as you can see. Bone around the sinus window is clean, no particles all over, goes quickly. And as you can see, just after placing the last chunk of cerabone plus, the bleeding already starts to connect to the particles. And here again, I have the two images 3-5 seconds after each other. On the right side, as soon as I place the particles, I have a little bleeding on the right already. 3 seconds later, if you could look at the image on the right, same area, the bleeding is already 2/3 or 3/4 of the entire area. Almost all the particles are already perfused with blood, all the particles. And that's what we need. We need blood for the osteoblasts to grow in and to have real natural bone between those particles to place the implants in later. So that's what we want. We want blood, we want osteoinduction and osteoblast, which comes from the blood. So it's good to see that. I love to see that. We place back the bony window and close up the area. Let's see the control panoramic x-ray here. Nothing special, right? Just a quite major sinus lift at the distal area of this patient. But I like to see here again, if you look at the radiopacity and the texture of this graft, look at that. If you go from mesial to distal, where is the outline of the graft? Where was the sinus floor? Where does the graft start? You can hardly see it, or actually, I'm not even sure I can see it. The texture, the radiopacity of the graft is really identical to the patient's own bone, and it's really good to see. I mean, if radiologically you see something exactly like the bone, probably it's quite similar to the bone, right? So let's go one step forward. These were just the contained defects. Let's go for a little less contained defects, minor horizontal augmentations. Let's see first one on the maxilla. Here we open up, it's a single tooth gap, so minor tooth loss here. We have about 4 to 5 millimeter width. Of course, we do a little bone expansion, place our implant. And as you can see, we do have a little bone on the buccal of this implant as well, but it's really thin. So it's less than a millimeter. So all the way on the buccal we have 0.5 millimeter or so. And we know we do a little expansion, this will not stay there for long. So it's not predictable. For long term, we want at least, known from the literature, at least 2 millimeter of buccal bone, stable buccal bone on the neck of the implant, on the buccal side of the implant, to have long-term stability and predictability. We place this one chunk of cerabone plus here. You can see I hold it up with my instrument in one chunk. Hyaluronic acid beautifully keeps it in place. When we put it in the area, you can see it sort of keeps its own volume. So it's not going everywhere. It's really nicely where the bone outline is, which is kept by the neighboring teeth. The bone particles beautifully stay there. Of course, we use a collagen membrane, we use a JSON membrane. That will definitely keep the particles there. That will prevent the soft tissue cells to grow inside that graft. But this cerabone plus material facilitates the function of our collagen membrane. So it doesn't make it more difficult for the membrane to keep it in place. It facilitates it. It nicely adapts on the bone and at the surface of the membrane. We just fold it over, nicely kept in place everything. Then we close it up. When we open it up, you can not spot the implant at first, right? That means we even gained a little bone. I didn't want that, but even vertically I gained a millimeter or so. So beautiful, and we have beautiful bleeding white bone. You can spot some little particles here and there, but it's a homogeneous, vital, bleeding, natural bone. Just to see here, this is the implant. We needed a little scraping to find the implant, but we found it eventually. And you see we have 2 to 3 millimeters of vital, bleeding, stable buccal wall. We do a little soft tissue grafting with some collagen just, and then healing abutment. And here in this case, we have a control x-ray of the patient after re-entry. So here's the peak healing abutment in, and you can appreciate from the coronal view how thick buccal bony volume we have, exactly the contour of the neighboring alveolar ridge is capped. And you can see that this bone is thick, stable, looks like a cortical bone, like the cortical bone of the sinus, the same radiopacity, same texture, and it's exactly until the neck of the implant, both palatally and buccally, till the neck of the implant, maybe even a little above that, and at least 3 millimeter on the width. So we have a really long-term stable outcome here. This will be the same in 10 years for sure, or in 2030, I believe. So let's see another case I just want to compare. It's a much older case of mine, not identical to this, but just let's see a little comparison. This was a 2-stage case using regular cerabone and about 40% of autologous bone. You can see the autologous chips mixed together. It was a 2-stage, 1-tooth gap, a single-tooth gap. So we wanted to give a little more vitality with the autologous bone chips. You can see the re-entry in the middle dual membrane technique according to Boozer, and you can see the re-entry. It's vital, it's bleeding. You can spot some particles still here, the bone graft particles, but it's vital, bleeding, perfect for implantation. If you put it side by side to this case, I would say in worst case scenario that the vitality, the texture, the homogeneous natural looking of bone is quite similar. I would say with the cerabone plus even a little better, even a more natural looking, but let's say it's the same, okay? But on the cerabone plus case, I was using 100% bovine bone, 0 autologous bone. This very similar case on the left, I was using at least 30 or 40% autogenous bone scraping of the patient. So this makes us question, in these minor horizontal augmentation cases, do we at all need autogenous bone scraping? Do we need this extra time, instrument, and morbidity for the patient if we are just doing contour augmentation, like according to the original Boozer technique? Or is it far enough to just use xenograft particles? Everyone decides for themselves. I believe we can do to only use xenograft, especially if you use cerabone plus in these kind of cases. Here you can see the initial start, soft tissue going into the palate, so no bony outline, no soft tissue outline of any kind at the beginning, and at the final delivery of the crown we can see that the convexity, the outline of the implant crown is basically identical to the neighboring teeth, which is what we want to achieve. Here is a really interesting case, I believe. It's also a single tooth loss, single tooth span, but it's in the lower mandible at number 6, so it's in the back. We have the base of the tongue there, the cheeks there, a lot of saliva there. So I don't know who many of you would agree, but I think it's one of the most difficult areas to work with all that saliva, all that soft tissue movement, with that less of visibility there. And you can see it's a huge defect, huge concavity at that area. When we open up at the cervical part, it's like 2 to 3 millimeter of bone. So with some bone expansion, we place the implants, but as you can see from an angle, we have this 1 millimeter little higher closure screw, but at least 3 millimeters of implant is completely exposed, and even below that, the next 2 to 3 millimeters is also really, really thin, and only at around, I don't know, 5, 6, 7 millimeters from the neck of the implant, it starts to get incrementally a little thicker. So that's not good, not looking good. So here we use the cerabone plus again, put there in 1 or 2 chunks, keeps itself in place, as you can see, look at that. So it's not spreading around everywhere, it's kept in place. The JSM membrane on top of it and closed. So on the left side, we can see initial clinical picture and after healing clinical picture. No soft tissue augmentation, no soft tissue graft, no extra collagen, just the GBR, the contour augmentation. You can see this extreme concavity at the beginning completely gone, and we have a slight convexity with no soft tissue graft, but we have a convex outline of the alveolar ridge with just doing this contour augmentation. And here is the x-ray where you can see, and I know it's not perfect, but I think it's important to see these kinds of cases. As you can see, I did a coronal view about 2 millimeters from the neck of the implant. And there, as you can see the particles a little bit, the graft. We have about 3 millimeters of buccal wall, really stable, thick, 2 at least, or rather 3 millimeters of buccal wall, 2 millimeters from the neck of the implant. On the lingual, as you can see on the right CT image, we have the bone level at the neck of the implant, but and there was a 1 millimeter closure screw, so the little higher I use in these cases. But you can see on the buccal, I have, if I'm very strict on myself, let's say 1.5 millimeter, but I would say rather 1 millimeter of bony dehiscence on the buccal, right? So we have 1 millimeter of the closure screw and 1 millimeter of bony dehiscence, but right under that, right apical to that, I have immediately 3 millimeters, and all the way I have 3-4 millimeters to the buccal, and really thick, stable, non-resorbing bone. And I would say in 10 out of 10 cases, I know it's not perfect, the best would be if I would have 3 millimeters at the neck of the implant, but it's the lower 6 with the saliva, with the cheeks, with the tongue. It's the most difficult area to work at, but I believe in this case, I'd much rather have 1 millimeter of dehiscence, bony dehiscence, on the buccal of the implant, 11.5 millimeter implant, and have 3 millimeter all the way to the apex from there. Then, if I could choose to have 0.5 millimeter or 1 millimeter of bone till the neck of the implant, because we know for sure that if we have 0.5 millimeter, if we have 1 millimeter on the neck of the implant all the way, the whole thing will resorb. In 1 year it will not be there, but for several years for sure it will not be there. But I can be positive that this bone, this thick, stable bovine bone mixed with autogenous bone, will stay there for years and decades, even having that 1 millimeter of bony dehiscence, which is not more than that. You can see the final crown on the right, and without any soft tissue grafting, the convex outline, which is aesthetic, which is cleansable, maintainable for the patient at home. I think it's a really, really stable outcome, although not a perfect case because it's not till the neck of the implant. All right, so let's see major horizontal augmentation, okay? So here I was talking about the ridge split and the GBR, the sausage technique. Let's see a case for both. So here you can see it's a several tooth span, a wider 2 molar wide major horizontal ridge deficiency on the mandible. You can see from 2 aspects. And when we open up, you can see on the mesial, we have about 3 to 4, maximum 3 to 4 millimeters of bone. On the distal, we have a little more to the apex. The distal implant we could place immediately with a little sinking of the implant. Still on the neck of the implant, really thin bone, so we want to augment there also. But on the mesial, just doing contour augmentation, I believe it wouldn't do because it's not a containing defect, it's flat. It's not between 2 teeth. There's no containing of this defect. So we do the ridge split here. The mesial implant is placed between the lingual and the buccal cortical plates. We do it with piezo. It's placed between the 2 cortical plates, and this way it's covered all the way with autogenous bone of the patient. But as you can see, a little apical to the neck of the implant, we can see through the implant. It's so thin, this bone. So this will not be stable over time for sure, although it's bone all over, right? So this is why we add some cerabone plus to the buccal to have really thick, stable tissues long term, and place a membrane on top. Here we can see the early healing. Already we can see the whole ridge is much thicker. Even like the soft tissue thing thicker, although there has been no soft tissue grafting at all, zero. And you can see after the healing abutments, the soft tissue contour at this area. So let's see a before after. At the left we have this really thin ridge at the area of 2 molars, and here at the healed side we can see the wide band of keratinized tissue, and we can see under it, basically almost see through under the soft tissue, we have a thick bony crest, thick hard and soft tissue surrounding of the implants. You can even see some particles, especially at the distal implant on the buccal, incorporating the soft tissue. That's no problem, no inflammation, it's perfectly healthy. But there is really a visible, thick, hard and soft tissue buccal outline, which we did not have at the beginning. So this tissue seems to be really stable and maintainable long-term for the patient. Let's see an even more severe case of horizontal bone loss. This is what we call usually the knife edge ridge. So even through the soft tissues, we can expect something really thin, unfavorable bony tissue. When we open up, just doing the elevation of the flaps, the releasing of the flaps, you can see it's really like a knife edge, it's like 1 or 2 millimeters on the edge, nothing, okay? So here we are not good enough with just using bovine bone, for sure. Here we use the 50% cerabone and 50% scraped autogenous bone of the patient, scraped from the retromolar area. We mix it together 50-50%. It's a mixed composite graft according to the technique of Dr. Orban, the sausage technique, and we expand a collagen membrane on top, fixate it with micro titanium pins. You can see the so-called sausage as this composite graft is fixated tightly on the ridge, on the curve of the ridge as it's supposed to be. And you can see some before after CT images. On the left we have the initial thickness and width of the alveolar ridge on the mesial, and the alveolar ridge on the distal. Here it's like even more drastic what we gained. We had like 2 something millimeters on the crestal for the beginning, and we have like 10 millimeters crestal after healing. So amazing 400% width gain or something like that. When we open up, you can see some particles. You can see always some bovine bone particles when we do a sausage technique, but it's bleeding, it's incorporated, it's vital. So I think it's beautiful. We place the 2 implants, look at from the crestal view. They're like suffocating in bone. Both have really extensive buccal bone all over. I mean, lingual and buccal bone, especially on the buccal where we have nothing. We have at least 2-3 millimeters on both implants. So it looks like a vital bleeding bone, really thick, really stable. This xenograft will not resorb. It's incorporated with the living autologous bone tissues. So I think this looks stable, and I'm pretty positive about the long-term results of this case. So let's go over to our last types of cases, which I said at the beginning is maybe the most challenging, most demanding of all cases, is the horizontal and vertical augmentation, where we also have a vertical loss of the ridge and major horizontal loss as well. The only thing generally worse than that is if we have all that in the aesthetic zone. And we know that in the aesthetic zone, every millimeter, every half a millimeter counts, both in soft and hard tissues. So this is the case when I say using mostly or in major part bovine bone. In my hands, in my humble opinion, it's not that predictable. So look at that. We have on the crestal 1 to 2 millimeters of width on the central and lateral incisor, a little more in between, but that's not where we want to place our implants. Huge vertical concavity as well. We can see the mesial part of the root of the canine as well. So incredible resorption of the bone. this patient had some kind of accident, so lost both the teeth, central lateral incisor, and all of the bone almost gone with it. So major horizontal and some vertical loss. We want to get all the living vital tissues here as possible. So in this case, we do the well-known Corey block technique. I take it from the retromolar area. We did piezo to have it really thin, 1.5 millimeters. We use the osteosynthesis screws and just use autologous bone scraping to fill the area. 100% natural autologous bone in this case. And my personal preference, maybe just because I'm a periodontist, but I also like to cover it with a thick collagen membrane, like a cold protect membrane, because it will sort of hide the screw heads and they will not stick out through the soft tissue, especially not puncture the soft tissue, and also make the soft tissue a little thicker if you place it, and you will completely prohibit. I know it's not really necessary to use it in every case, but you will definitely prohibit all soft tissue ingrowth in the graft, and also make tissues, soft tissues a little thicker, and cover those screw heads from puncturing the soft tissues. You can see this minor vertical defect at the beginning, especially look at the buccal. You had like 3 to 4 millimeter of buccal concavity bone loss, and after this Corey technique, placed a little vertically in a more coronal position. We do not have the prosthetics yet, but you can see that this vertical and horizontal loss, it's completely vanished. We have quite a nice horizontal hardened soft tissue complex where we have the chance for that papilla, which we really want to gain between the implants. And I believe in these demanding situations, the most predictable is still, just in these cases, is still using autologous bone. So I believe there is still relevance of using autologous bone at large, for example, vertical bone defects. However, most of our daily cases, I believe at least 80 or rather 90% of our daily cases can be managed without it by using state-of-the-art biomaterials like the Cerabone Plus, either alone or with minor usage of bone scrapings from the surrounding areas. And that's a real leap in bone augmentation compared to the past 2 to 3 decades. So let's see, for finish, why is Cerabone Plus different? Why I like it so much? What is special about this material? So for first, I think it's definitely the first ever out-of-the-box particulate bone graft with volume stability. By volume stability, I don't mean like a bone block, right? Of course not that kind of volume stability, but still, within particulate graft, definitely it has the most volume stability in all of them. Which means when I place it in the alveolar socket, when I place it in the sinus, it keeps its volume, it keeps its place, its shape. So it's easy to work with like that. And also if we're using a membrane to cover it, it facilitates the function of the membrane, it helps it. It keeps its shape to put the membrane around. It doesn't go in every direction, so you have to tuck it under the membrane 20 times before you can fold it over. So it really helps with sort of keeping the volume by itself and facilitating all structures like membranes to retain that volume. Also, by this increased ease of handling, which I showed you in every case with this my instrument, my spatula, I can like take little balls or chunks of Cerabone Plus and, for example, do a major open sinus lift with just 2 or 3 pieces, just shift it into the sinus window with real ease, with clean handling, and this reduces surgery time by a lot. So instead of by particle filling up a sinus, just 2 or 3 shovels and it's full, and it actually works like this. So it's increased ease of handling, reduces surgery time in every case, in my experience at least. Also, because of the particles keeping themselves together, they will not flow and roll around your surgical area, and it will not get incorporated in the soft tissue, which will cause aesthetic problems for the patient, maybe even inconvenience or even little pain for the patient, because those little particles the patient might see in the anterior, it's whitish, feel with the tongue, or maybe even irritate the gums, the soft tissues, and that's not good for the patient, not good for us. Even if it's, we all know, I think, or at least I know, I have experienced it several times, when we open up these areas, let's say after an open sinus lift, where the particles were not contained, with the scalpel and with your plier, when you open up the flap, you can feel that it's a hard tissue, not healthy gum which you are retracting there, because it's full of these little particles. Of course, it can still work beautifully, but it's not a healthy, intact gum. It's somewhat crunchy, it's somewhat stiff, because all these particles incorporate, and with the Cerabone Plus you can completely prevent that. It just never happens. It keeps together, it doesn't flow all over. So that's another great advantage. The patient will not have the aesthetic and inconvenience problems with the particles. I had a couple of times in the past that the patient feels, what is that? It's a particle, we might have to even take it out of there, or if it's not in a too worrying area, you can leave it there, but it's not convenient. So this stops by using this material. And also, which is something I have to point out, it's no evidence, it's no literature, it's just my personal experience, that it's 0 to minimal pain and swelling reported by the patients after using this material. I cannot exactly explain this, but it has happened. So I had patients doing like major open sinus lifts or contour augmentations, or this sort of major interventions which last for a while, needs quite amount of material. And patients reported me right the next day, 2 days after, that sometimes the patient came back and the next day of the surgery and I didn't see any swelling, and I didn't understand, how don't you have any swelling? When I used to do a sinus lift previously, at least for 2-3 days, some swelling they always, or not always, but most of the time they have. And I have in several times experienced several cases that patients, even like an open major sinus lift, have no swelling and basically no pain. I had patient, I asked how many painkillers he took. It was a colleague of mine doing a sinus lift, and he said, yeah, I took one in the surgery because you advised me to have one before the pain even starts, but that was the only one. So not even in the evening, not next day, I haven't took a single painkiller after a major open sinus lift. So it's pretty amazing. Also, there is another experience, or let's say a gut feeling of mine, maybe that's the right word, because it's no literature supporting this, I emphasize again. So supposedly there's a greater vascularization, and probably in a shorter time with the Cerabone Plus containing this hyaluronic acid than with the grafts, with any grafts which do not contain this. Remember the pictures I showed you just a couple of seconds after each other, the same case, same area, just a couple of seconds, and in one instance the blood perfuses, infuses, goes between around the particles, and it's like calling for the blood, you know, this material. And I like to see it. And also after reopenings, I see in shorter time more bleeding, more vitality. There is nothing literature yet behind this, but I have the gut feeling that the vascularization in this material, probably due to this hyaluronic acid adding, it's greater, it's more extensive, and I think it comes even in a shorter time, as the blood also touches the particles in a shorter time. And last but not least, I think it possibly reduces even the need or amount of autologous bone in some cases which classically need autologous bone, mixed graft cases, composite graft cases, like the contour augmentation described by Boozer in the early 90s. We know that we need a layer of autogenous bone on the implant surface which is exposed, and only on top we place the xenograft and the double layer membrane. So that's the classical technique from 30 years ago, but we need to evolve, I think. And my experience, and we can see more and more from colleagues and in the literature, that in these minor cases we already shifting from xenograft bone replacement material and autogenous to just reduce it to bone replacement material, xenograft without autogenous. So I think that's where we are now. But technology and materials change, so there might be a time when even in the most demanding cases, which are vertical defects in this case, we might not need autologous bone or less autologous bone than now. So that was my little experience and my humble opinion about this material, about this amazing new material, the Cerabone Plus. And with a picture of my home city, Szeged, I would thank you everyone for your kind attention. Thank you very much for being here. Bye.